Welcome to the deep dive. Today, we're really getting into the nitty-gritty of asthma management.
We are indeed.
We've got the very latest guidance, hot off the press, you can say. November 2024 updates from the British Thoracic Society, NC, and SciGN.
That's right.
Think of this as, well, your personal decoder ring for understanding how experts are now recommending treating asthma across different ages.
Our goal today is really to get right to the heart of it.
Yeah.
The key treatment pathway.
For different groups, right?
Exactly. Children under 5, then those aged 5 to 11, and finally anyone 12 and over.
And this is coming straight from these new recommendations.
Straight from the guidelines, we're aiming for clarity, structure, giving you the essential insights without getting too bogged down.
Okay, sounds good. Let's dive straight in then. Youngest first children under 5.
Right.
Now, the very first step in their treatment algorithm, it might sound obvious, but it seems absolutely critical.
It really is.
Before even thinking about reaching for an inhaler or changing a dose, we need to understand why their asthma might not be controlled.
Precisely. The guidelines really stress ruling out other possibilities first.
Such as?
Well, could it be another condition that looks like asthma? Is the child actually taking their medicine as prescribed? That's adherence.
And how they use the inhaler.
And is their inhaler technique spot on? Critically important. Then there are the environmental factors.
Right, things around them.
Yeah. Passive smoking, and that includes e-cigarettes now, specifically mentioned, seasonal triggers, air pollution, even indoor mold.
That seems like a stronger focus, the indoor air quality.
It does. The updated guidelines seem to place a bit more emphasis there, especially mold and e-cig exposure, probably reflecting newer studies on young lungs.
Okay. So for a child under 5, suspected asthma needing regular treatment, or maybe after a bad flare-up, what's the initial move?
Usually it's an 8 to 12-week trial, twice daily low-dose inhaled corticosteroids, ICS for short.
Okay, low-dose ICS.
And that's alongside a short-acting beta agonist, a SABA, for, quick relief when symptoms flare up.
The reliever inhaler.
Exactly. The SABA just relaxes the airway muscles quickly to ease breathing.
So what happens is, during that 8-12-week trial, the symptoms, well, they just don't get better.
That triggers a really thorough reassessment according to the guidelines.
Okay.
You double-check the inhaler technique again, you check adherence again, look closer at those environmental triggers.
Like the mold or smoke.
Yes. And you even reconsider, is the diagnosis of asthma actually correct? Could it be something else?
And if none of that explains it?
Crucially, then referral to a specialist becomes the essential next step.
Right. Okay, but what if things go well? What if the symptoms do settle down during that trial?
That's obviously good news, but the approach is still quite measured.
So you don't just stop everything?
Not necessarily straight away. After the 8-12 weeks, you might consider stopping the ICS and SABA, but, and this is important, there needs to be a careful review after another 3 months.
Just to make sure things stay settled.
Exactly, to ensure the asthma remains well controlled off treatment.
Makes sense. You don't want to jump the gun. What happens, though, if things take a step back? Symptoms come back after that review. Or maybe the child has a serious flare-up needing oral steroids or even hospital.
In that situation, the guidance is to restart regular ICS treatment back at a low dose.
Okay.
If needed, this could be stepped up to a moderate pediatric dose, but always still with the SABA for quick relief.
Still need the reliever.
Always. And interestingly, the guidelines also mention you might consider another treatment-free trial later on, but only after the child's been reviewed within the next year or so.
Okay. Now, to know when to make these changes, how do the guidelines actually define uncontrolled asthma for these little ones, under 5? What are the sort of red flags?
Good question. For under 5s, it's defined by either having any exacerbation bad enough to need oral corticosteroids.
Right, needing steroid tablets.
Or having frequent regular symptoms.
And what counts as frequent?
That means needing their reliever inhaler, the SABO, on 3 or more days in a week, or waking up at night because of asthma symptoms 1 or more times a week.
Okay, so reliever used 3+ days a week, or waking up once a week or more. Got it.
That's the threshold for uncontrolled?
So, if a child hits that definition, what's the next suggested move in the guidelines?
The recommendation, then, is to think about adding something called a leukotriene receptor antagonist, an LTRA.
LTRA.
Added onto their current ICS treatment. But it's usually for a trial period, again, 8 to 12 weeks.
And you watch closely.
Absolutely. You need to see if it's actually working and check for any side effects. If it's not helping or causing problems, the LTRA should be stopped.
Right. And what if, even with the ICS and the LTRA trial, the asthma just stubbornly remains uncontrolled?
In that case, the guidelines are pretty clear. Stop the LTRA and the child needs referring to a specialist.
Okay. A specialist referral again.
Yes, for that more in-depth assessment and management plan.
Right. That gives us a really solid picture for the under fives. Shall we move up in age group? Children aged 5 to 11.
Let's do it.
Is the initial thinking here broadly similar?
There are definitely parallels. That first step is still absolutely vital about identify and address reasons for poor control.
The same checks. Adherence, technique.
Yes, adherence technique, environmental factors, alternative diagnoses, but maybe also considering active smoking in this slightly older group, although hopefully not common.
And psychosocial factors too.
Yes, psychosocial factors are mentioned too, which can sometimes impact how well a child or their family manages the treatment plan.
Okay. And for a child in this age group, 5 to 11, who's newly diagnosed, what's the recommended starting point?
Again, pretty similar to the younger ones. Start with twice daily pediatric low-dose ICS plus a SABA for relief.
Standard approach there. Now, we often hear about MART maintenance and reliever therapy for older patients. Does that come into play here for the 5 to 11s?
That's a really key point and a distinction. So MART, as you said, uses a single combination inhaler.
The ICS plus a long-acting reliever.
Usually ICS plus formoterol, which is long-acting but also fast-acting. So you use it for daily prevention and for relief when needed.
Sounds convenient.
It can be. However, the November 2024 guidelines specifically point out that at that time, no inhalers were actually licensed for MART use in children under 12.
Oh, right. So none had the license for that age.
Correct. Which means any use of MART in the 5 to 11 age group would be considered off-label.
Okay, that's important for people to know. Off-label use.
Yes.
But interestingly, even though it's off-label, the guidelines do still outline a pathway for kids in this age group who are thought to be capable of managing a MART routine.
They do. For those children judged able to handle it, the guidelines suggest considering pediatric low-dose MART.
Oh.
If their asthma is still uncontrolled on that, then stepping up to pediatric moderate dose MART might be considered.
And if that doesn't work?
Then, just like we saw before, referral to a specialist is recommended if asthma remains uncontrolled.
Okay, but what about the kids age 5 to 11 who aren't suitable for MART or can't manage that approach? What's the alternative path for them?
For those children, the guidelines again bring in the LTRA option.
Right.
Add an LTRA to their twice daily low-dose ICS, again for an 8 to 12-week trial.
Same principle.
Yeah.
Stop it if it doesn't work or causes side effects.
Exactly the same principle. Assess effectiveness and tolerability.
And if their asthma still isn't controlled, even with the low-dose ICS and the LCRA trial, what then?
Okay, the next step up is to consider offering a combination inhaler. Twice daily pediatric low-dose ICS plus a long-acting beta agonist, a Labier.
ICS LABA combo.
Yes. And that can be tried either with or without continuing the LTRA.
So you might keep the LTRA going alongside the combo inhaler.
You might, yes. If control is still not achieved, the guidelines then suggest moving up again, this time to a twice-daily pediatric moderate-dose ICS-LABA combination.
Moderate dose combo.
Again, with or without the LTRA.
And if even that doesn't get things under control?
Then the recommendation, as we've seen consistently, is referral to a specialist.
Okay. Now, just quickly, the definition of uncontrolled asthma. Is it the same for these 5 to 11-year-olds as it was for the under 5s?
Yes. Exactly the same definition is used.
So needing oral steroids for a flare-up, or using the reliever 3+ days a week, or nighttime waking 1+ night a week.
Correct. That definition holds.
Right, clear. Okay, we've covered the younger groups. Let's move on now to individuals aged 12 years and over, teenagers and adults.
Okay.
What are the key sort of shifts in the approach for this age group according to these updated guidelines?
But you won't be surprised. The algorithm, again, starts with that absolutely crucial first step.
Addressing underlying reasons for poor control.
You've got it. Check for alternative diagnoses, check adherence, check inhaler technique, check smoking, active and passive, including e-cigs, again, psychosocial factors, environmental triggers, all of that.
Still step one, always.
Always step one.
Okay. But then, for someone aged 12 or over who's newly diagnosed with asthma,
Yeah.
what's the recommended initial treatment now? This seems like a place where things might differ.
They do differ here, actually. It's quite interesting. The guidelines recommend offering a low-dose ICS combined with formoterol.
The fast-acting LABA.
Yes, in a single inhaler to be taken as needed for relief, but it also provides the maintenance dose.
So that's basically MART, or sometimes called air therapy, right from the start.
Essentially, yes. For newly diagnosed people aged 12 and over, they're recommending starting with an ICS formoterol reliever-triggered approach.
Wow, okay. That is a significant change from starting with just regular ICS for the younger groups.
It reflects an evolving understanding, suggesting this might be a better initial approach for many in this age group.
Okay. What about people age 12 plus who already have an asthma diagnosis? Maybe they're being switched from older guidelines. Perhaps they were on just low or moderate ICS or even just a SABR reliever.
Right. For those individuals with an existing diagnosis, the guidelines suggest a few options. One is to offer a low-dose ICS-LABA combination inhaler as their regular maintenance therapy, twice a day usually, with a separate SABA kept for quick relief if needed.
So fixed dose combo plus SABA.
Yes. Another option is to continue with their regular low-dose ICS and add a supplementary LTRA.
ICS plus LTRA.
Correct. And importantly, if their asthma was uncontrolled on whatever they were taking before,
Yes.
then considering a switch to a MART regimen is strongly recommended.
So MART really seems to sort of take center stage for this 12 plus group, whether starting out or stepping up.
It certainly features very prominently in the algorithm for this age group, yes.
So what if someone in this group is already on, say, low-dose regular ICS, but their asthma isn't well controlled by that definition we keep using?
In that situation, the guidelines suggest you'd consider either moving them onto a MART regimen
Okay, switch to MART.
or alternatively increasing their regular maintenance ICS dose up to a moderate level. So moderate dose ICS twice daily.
Right. And if they're already on moderate dose ICS, maybe with or without a LOBA,
Yeah.
and still having problems, still uncontrolled,
Okay, here the recommendations get, as you said earlier, a bit more nuanced. Several options.
let's hear them.
One is to consider moving to, or ensuring they are on, a moderate dose ICS-LABA combination inhaler if they weren't already.
Okay.
Another is to stick with the moderate dose ICS, but add other treatments on top. So adding an LTRA or adding a LAMA.
LAMA, what's that?
LAMA stands for long-acting muscarinic receptor antagonist. It's another type of long-acting bronchodilator, works slightly differently to LABAs.
Another way to help open the airways.
Exactly. So you could add an LTRA or LAMA, or potentially both, on top of the moderate dose ICS.
Okay. Any other considerations at this stage?
Yes, the guidelines also suggest, if the tests are available, checking the patient's FeNO level, that's fraction of exhaled nitric oxide, a marker of airway inflammation, and their blood eosinophil count. These can sometimes help guide treatment.
How so?
Well, if neither of those markers is raised, suggesting maybe less eosinophilic inflammation, the guidelines suggest then considering a trial of adding either an LTRA or a LAMA to the current ICS.
I see. So those tests can help decide between add-on options.
They can potentially help tailor the choice, yes.
Okay. And what's the final step? If someone aged 12 or over is already on high-dose ICS, maybe with these other add-ons, and their asthma still remains uncontrolled?
At that point, when you're at high-dose ICS and still not getting control, the recommendation is clear: referral to a specialist asthma service.
Specialist referral for complex cases.
Yes, for that higher-level investigation and management, potentially including biologic therapies.
And just to confirm, the definition of uncontrolled asthma for this 12-plus age group, still the same.
Still exactly the same definition used throughout all the age groups we've discussed.
Oral steroids needed, or reliever used 3+ days week, or nighttime waking 1+ night week.
That's the one. Consistent across the board.
Okay. Now, you mentioned doses low, moderate, high ICS. The guidelines include a table, Table 1, specifically for the 12-plus group, right? What does that show?
Yes, Table 1 is a very practical tool for healthcare professionals. It lays out specific examples of what constitutes a low, moderate, and high daily dose for the different types of inhaled corticosteroids commonly used in this age group.
Can you give some examples of the ICS types listed?
Sure. It includes medications like beclomethasone dipropionate BDP, budesonide, cyclophosphamide, fluticasone propionate, fluticasone furoate, and mometasone furoate.
And it gives the actual microgram doses for low, moderate, high for each.
Exactly. It provides those specific dosage ranges, which helps ensure everyone's talking about the same thing when they say low dose or moderate dose. It helps standardize treatment adjustments.
That sounds incredibly useful for practical application.
It is. Very helpful reference.
So stepping back and looking across all these different age groups and their specific pathways, what are the big overarching themes or considerations that really jump out from these updated guidelines?
Well, several things really stand out, I think.
Go on.
Firstly, that constant upfront emphasis in every age group on identifying and addressing those potential underlying reasons for uncontrolled asthma before just escalating medication.
That check adherence, check technique, check environment step.
Exactly, it's fundamental. Secondly, the consistent definition of what actually counts as uncontrolled asthma, based on oral steroid use and the frequency of symptoms.
Same definition across the board.
Yes, makes it easier to apply. Thirdly, the ongoing role of SEBAs, the short-acting relievers, for quick symptom relief across all ages, even with the rise of MART.
Still need that rescue option.
Often, yes. And finally, the guidelines just repeatedly hammer home the critical importance of correct inhaler technique and good adherence. You can have the best drug in the world, but if it's not taken correctly or not taken at all,
It won't work. Simple as that.
pretty much, they are absolutely fundamental to making any of these strategies effective.
Makes complete sense. Now, beyond the specific drug algorithms, the guidelines also offer more general advice for people living with asthma, don't they?
They do, yes. A whole section on broader asthma advice and self-management.
What kind of things does that cover?
Oh, a whole range. Things like actively trying to avoid known personal triggers, dust
Yeah.
mites, pets, cold air, smoke, whatever they may be.
Right.
Proper inhaler technique gets another mention, naturally. The value of keeping a symptom diary, maybe tracking peak flow readings, PEFR,
Peak flow, yeah.
encouraging regular exercise while being mindful of exercise-induced asthma and how to manage it.
Healthy lifestyle stuff, too.
Yes, healthy eating, keeping up with vaccinations, definitely the annual flu jab, and the pneumococcal vaccine where appropriate.
Practical things like travel.
Absolutely. Advice on managing medications when traveling, the importance of regular follow-up appointments with your GP or asthma nurse.
Keeping those checks going.
Yes. And really importantly, always having and understanding your personal asthma action plan
Yes, the action plan.
and knowing when and how to get emergency help if needed.
Can you just briefly explain what an asthma action plan typically involves, as described in these guidelines?
Sure. It's basically a personalized written plan that you work out with your doctor or nurse. It helps you manage your asthma proactively day to day.
How does it usually work?
Often uses a simple traffic light system, green, yellow, red zones.
Green means.
Green is when your asthma is good, well controlled. It details your usual daily preventative medications.
Yellow.
Yellow means caution, your asthma is worsening. It tells you what extra steps to take, maybe increasing reliever use, maybe starting steroids, and when to contact your doctor.
And red.
Red is the danger zone, severe symptoms. It outlines immediate actions, like using your reliever multiple times, and stresses seeking emergency medical help right away.
So it's a clear guide for what to do when.
Exactly. It should also include knowing your personal best peak flow reading, if you use one, and have really clear instructions on managing exercise-induced symptoms too. It empowers the patient.
This has been, honestly, a remarkably clear and really insightful deep dive into these latest asthma guidelines. Thank you so much for breaking down what can seem like quite complex algorithms.
My pleasure.
It really is striking how, while there are definite tailored approaches for different ages, those core principles, first understand why control is poor, consistently monitor, use a stepwise approach, they just run right through it all.
They absolutely do. But it's crucial, isn't it, to remember what we've discussed here is an overview. It's about understanding the guideline recommendations.
Yes, absolutely essential point.
It is absolutely not intended as a replacement for personalized medical advice from your own healthcare professional.
Definitely not. We strongly, strongly encourage you, the listener, to have a proper chat about your specific situation or your child's situation and your asthma management plan with your own doctor or asthma nurse. They know you best. And just on that note, maybe a final thought for you to mull over. Considering these really detailed, age-specific strategies for managing asthma, well, what other chronic conditions out there might really benefit from such a highly personalized, age-aware approach to treatment?
Interesting question.
Something to think about, perhaps, until our next deep dive.